So my background is that I am a physician assistant, and I've worked in community health centers in the Bay Area for most of my career. So I don't see patients right now in the clinics, but I have worked at Asian Health Services, La Clínica de la Raza, Berkeley High School Health Center, which was never a dull moment, and healthcare for the homeless, things like that. So my disaster medical background, though, is that I am a member of a federal disaster medical team. So we go to the really big events. And so we were at Ground Zero week 5 and 6 for the World Trade Center. For Hurricane Katrina, my team ended up at the Superdome, which was the longest 20 hours of my life, and it really was hell. And I can come back and tell you stories sometime if you want to get depressed about how our country responded to disasters at that time. And then we also were in Haiti, which was a very, very meaningful response for us. And more recently, a different type of disaster was the number of minor children coming across the border. So it wasn't my whole team. I went because I worked in community clinics and I speak Spanish. So it was taking care of families that needed care coming across the border. And that is kind of an ongoing crisis. I heard that there's a surge again of unaccompanied minors and families coming across the border. And for me, it was really very easy because as I was taking care of the kids at the Border Patrol Station, which is kind of set up like a jail. They have cells, not bars, but glass windows and things like that. I felt like I'm back at La Clínica because these kids were actually the kids that we see at our community health centers. They're just farther along the migrant route. So, it's the same population that kind of blends into our communities. And we also work the wildfires. We don't fight fires, we're not that good, but we keep the firefighters and the inmates who form the hand crews fighting the fires, kind of when they're injured, or at that time it was mostly poison oak. So anyway, when I talk about first aid and prioritizing patients and disasters, it's based upon that experience, and that's why I try to teach you things that are intuitive. The other thing that I should mention before I forget, this book was here in your cache, and if you want to take an additional first aid class, I highly, highly recommend that you take a wilderness first aid class. The Red Cross does a perfectly good job with their first aid class, but one of the main things they teach you is, that might be broken, call 911. So what we're trying to do is to help you to figure out what you do when 911 doesn't answer. Yes. So to me, that's the limitation of the Red Cross class. But they do teach this at REI. It's not cheap, but it's a very, very good class. I took it for fun, and what they do is they do a lot of scenarios, so they break you into teams so that you do have to go, oh my God, there's victims all over here. Where do we start? And then once you've done it a few times, it really gives you that confidence that I remember this. Okay, I start where I stand and I do triage. So if you want to get into kind of the feel of, what might this feel like? The wilderness first aid class is an excellent way to do it. And if you've got lots of money and you love to ski or you really are into wilderness, then take the wilderness class at their headquarters, which I can't remember if it's in Colorado or if it's in New Mexico, but you get kind of the full wilderness experience. But that's the Wilderness Medicine Institute. Okay, so what I'm going to start with is talking about triage or sorting patients, because one of the hardest things that you're going to face is that if you've got a bunch of victims and you've got a limited number of people, then where do you start, or how do you make yourself most effective? And it's called triage, which means sort, but disaster triage, are anybody here medical background?
Many years ago.
And what did you do?
I was a nurse 40 years ago.
Same here.
Nurse?
Former.
I worked for orthopedists and GPs for many years.
So the traditional way of thinking of triage is the most critical goes up to the operating room. And for those of you, how many used to watch ER? See, this is an older group. A lot of folks used to watch ER. One of the main themes was that, the two doctors are arguing who is the most critically injured, and that's the one that goes up to the operating room. Then the pathos, of course, is that the bad guy with the gun is more critical than the police officer who is shot, so the bad guy with the gun goes up to surgery and gets saved, and the police officer dies in the emergency room. Okay, but what we're faced with in disaster situations is doing the most good with limited resources. So this is when you dial 911 and you don't get an answer, and it's not just that you got put on hold, which happens every day, but that they really are not going to respond. So one of the concepts that I want you guys to walk away with is doing the best for the most using the least. Doing the best for the most using the least. And what that means is doing the greatest, and it's in your notes, doing the greatest good for the greatest number of people using limited resources wisely, because in every disaster you don't have everything that you wish that you had, including an ambulance right outside the door ready to take somebody to the emergency room. And treat as many as possible who have a chance for survival. So that's another difficult concept that I'm going to talk about in a minute. And I'm going to use CPR as an example of why, how you don't use all resources. So how many of you have taken a CPR course? 1, 2, 3, 4, 5, 6, 7. So about half of you. So if you'll remember in CPR courses, there's this chain of life, right? And it starts with you recognizing that somebody has had an emergency and starting CPR in the field. And at the end of that chain of life, you have actually somewhere between 7 and 14% chance that that victim, if they're having a heart attack, is actually going to survive to leave the hospital. That's a pretty small number considering how much effort you're putting into this. But it means recognizing, activating 911, starting CPR in the field. Then that chain of life then depends upon rapid ambulance response that takes them to the emergency room, where they will rapidly be triaged, and in a disaster that could be a mob scene, and sent quickly up to the cardiac care unit, where they can then do this thing called an angiogram, and then from there, they'll decide whether to do open heart surgery or, there's a number of procedures. Then from there, they need to have that surgery, which could take hours, and they go then to intensive care, and from there to step down, and there to rehab. So that you can already imagine when we have the major earthquake, that chain of life is broken in many places, not just in one place. But, instead of if you start CPR, then you continue until, right, either you are relieved by somebody of equal or higher training, or you are exhausted and cannot continue. So for that period of time, you are not available to help somebody else. And we're going to talk about stopping bleeding and treating for shock as being like the most effective thing that you can do. So you're not available to do that. And then you know that you haven't heard an ambulance, like in the last 4 hours, and that you've heard that the emergency room is actually completely inundated, things are crazy, and you're thinking, well, it's not really likely that they're going to do open heart surgery when they could save 6 other people in the amount of time that it would do to do a coronary bypass. So if you know at the beginning that chain of life is broken in many places, and you're really quite sure of that, and you have other victims, that maybe you shouldn't start CPR at the beginning. Now that patient is still your patient. So you're going to find out their name if they're conscious. You're going to provide supportive care. You're going to be there with them. And if things clear out and you can help them more, then you're going to do those things. So you're not abandoning the patient, but maybe you're not going to start the CPR, which will then tie up you and other resources. So that's part of the disaster thinking. So more than thinking of, okay, there are all these people, then we're not going to take care of. No, what I'm going to try to teach you are the things that are most effective. Because I'm going to give you the punchline right now, that the most important thing that I think you can do out in the field is to stop bleeding. Because that's something that you are there to do. It needs to be done within minutes. my team might be coming day after tomorrow, but by then that person will have already bled out. And it's something that everybody can do. And last few weeks ago, we were teaching children how to do it. Now, they might not be able to stop a big bleeder, but they can stop bleeding and treat for shock using their hands to put direct pressure on something. So this is a skill that, we have actually at certain times taught Berkeley Unified School District staff and teachers, because they're the ones who are going to be there for the kids to do that. So that's the type of prioritization, and for you to also feel confident that that's something that I can do and it's going to make a difference, even if I don't remember the 13 other conditions that we might need to train on. So that's kind of the CPR. Take a CPR course, learn it, but don't do that thinking that that's the first skill that I'm going to use in a real disaster, because it's actually one of the less likely skills that you're going to use. Now, if you have enough people and you can do CPR with the number of people you have, go ahead and do it. I'm not saying that you shouldn't do it, but when you're prioritizing limited resources, those are the types of things that you consider. So, okay, the second concept, so the two most critical concepts actually come at the very beginning. Doing the best for the most, using the least. And the other is this concept of phases of death. And this is also in your notes, and probably on the video you can put it up on work that into the editing. So the phases of death, they break it down into 3 phases. The first is there are people who, without expert intervention, are going to die within minutes. And that we think of that as people who have injuries to their vital organs. So that's a severe head injury. Kind of the head and the trunk is one of the ways that you can think of it. So if somebody has, a severe injury to their heart, their chest, their abdomen, or their head, they probably need to be in the emergency room or at the hospital. Which means that here in the neighborhood, there's really not a whole lot that you're going to be able to do. Again, this is somebody, they're your patient, you want to get a name, somebody stays with them, you provide supportive care, you keep them comfortable, you're not abandoning them, but it helps to realize that out here in the neighborhood, you are probably not going to be the critical factor in whether they survive. The critical factor is going to be, whether you can find a way to get them transported. Then there are people in the second phase of death, which are people who, without intervention, will die within minutes to hours. And that's largely people who are bleeding. And that is the group where you can make the most difference. The people who are intervening in the next minutes to hours is going to really make a difference with the resources that you have. Then people in the third phase of death are people who have injuries that are actually stable. That can wait for a longer period of time. And these roughly correspond to your triage colors of red, yellow, and green. Red being urgent, need intervention within, as soon as possible, will destabilize. Yellows being people who have serious injuries but are stable for the moment. A classic example of that would be a fracture. Fracture is serious, but unless it's also bleeding, a fracture actually can wait until day after tomorrow, actually. And then the minor injuries. And then I've been teaching this for a number of years, and then somebody in one of the classes said, oh, I learned this before, but they taught it a different way. So what they said is people in that first phase of death are going to die no matter what you do. The people in the second phase of death are the people where what you do is going to make a difference, and the people in the third phase of death are not going to die even if you do nothing. So that's another way to think of it. I said, I hadn't learned it that way, but that actually makes perfect sense. So that's a little bit, I talked a little bit about triage. So red being the ones who urgently need to be taken care of. They're your highest priority to do something with. And we're going to talk about stabilizing. And then yellows being those who have serious injuries, fractures, deep lacerations, pretty bad bang to the head, an injury to their torso, but, this really looks like they're stable for the moment. and then the greens being those who can wait actually a long period of time. And one excellent thing to do with your greens is to have them help you with other things, because they go from being the victim who has a hurt on their hand to being, I'm a victim with something hurt on my hand, but I helped that lady over there because I did such and such. And then now they're not just a victim, they're actually a responder. And that makes a huge difference in how they remember and perceive what happened. And then also it helps you out because you've got somebody to stay with somebody else. So you use your greens and get them to work. Then there are people, so the other two categories are gray and black. So one of the things that happened in Katrina was that we had a lot of patients where they weren't going to make it, but they also weren't going to die right away. And this largely in Katrina were people with very, very complex medical conditions. So, we had a lot of people who were dropped off by nursing homes and ended up at the Superdome. And we had our supplies are mostly for trauma. They're not for, we don't have lab, we don't have IVs. And so, these were patients who had terminal cancer, who, might have Alzheimer's, although that's not necessarily an acute medical diagnosis. Or unstable cardiac conditions who you can't just like run an IV full bore. You have to actually know what their electrolytes are, which we don't have. Or they really needed advanced nursing care, with somebody who's going to attend to them and those were things that just were not available at the Superdome. The Superdome was so filthy that when I had a patient with a wound, I generally did not unwrap it. Because because there was a lot of things were contaminated with water that had been in the floods, which was feces contaminated, and things like that. So grays are patients who are not dead, but who you don't have the resources to make a difference. You have the resources to support them, to make them comfortable, to have them know that somebody's looking after them, that you know their name, that you're trying to get them transported, but you don't have the resources to change the course of what's going to happen to them. So to me, those are grays. Those are sometimes also called expectants. And, like I said, sometimes they, we think, well, either they're red, yellow, green, or they're black. And then, black means that they're over there, and that's the one that we don't really talk about. But to me, your grays they're people, they're human beings, but you need to recognize that, I'm going to make you comfortable, I'm going to keep you horizontal, I'm going to bring you water. If you have any medicines with you, I'm going to help you to take them. But I'm not going to put our one doctor on taking care of this particular patient. We're going to provide supportive care. So those are kind of the categories. The reds, the ones that you want to get to as soon as you can. The yellows are the ones that you recognize you have to keep an eye on. They have serious injuries, but they can wait a little longer because they're stable. Again, one example would be a fracture. The fact that they have a broken bone probably is not going to kill them unless they're bleeding. And then if they're bleeding, then that becomes a bleeding issue, which is an urgent issue. And if you're not sure if it's broken or not, because you don't have an x-ray, well then you splint it, because it will be more, whether it ends up being broken or just badly bruised, it actually is going to be more comfortable to them if you splint it. And if it's obviously broken, you don't need an x-ray, because it's obviously broken. So, right. So fractures are kind of a good example of something that can go, kind of in different directions, and that you don't need to freak out about it unless it's bleeding, in which case you treat it as bleeding. Okay, so that's the red, yellow, green, and black.
I'm sorry, what was black?
So black are people who are dead. Yeah. Yeah. Okay, so do you guys use triage tags? Do they give you triage tags?
I don't think there are in our kit.
Yeah.
I don't think
Okay,
so.
that's fine, because I do this semi-professionally. This isn't my day job, but we are professionals when we go, and I can't make heads or tails of these. So I think that the main thing that these are good for is this thing, it's the barcode. So that if you are going to transport somebody and you do have these, then you can attach one of these. If they're being transported officially, the paramedics will have these, so you don't have to worry that you don't have them. But they do get entered into a national system for tracking because in Katrina we lost track of a whole lot of people. So what I suggest instead of this are these. And we used a version of this in Haiti. In the slideshow I actually have a picture. But the way, because the red, yellow, green, gray, and black are universal, and it's helpful if you get them tagged that way. And also, when the paramedics show up, they're going to say, where are your reds? And you go, there, yeah, that's right, they're over there. And then you kind of visually make sure that you got that right. So, can I have a victim stand up here?
It looks like if you're wearing black, though, and you know what black means, it's going to be very mentally
So
stressful.
that's why, okay, that's an excellent question, which is that, you know, if you tag somebody black, then either the victim or their family are going, what's that? And so this works for people who are dead.
Okay.
And that's why I get another color, this is what I encourage you to do, which your team knows means gray. Okay, or it can be gray.
Okay.
And then you can kind of fudge and decide how you're going to describe that. But to me, black means dead.
Okay.
Or they are so far gone that, you know, they're completely unconscious and they're unresponsive to everything. But to me, until they're dead, you still keep an eye on them and things like that. Okay.
So your blue is really gray.
Yeah, and then you can use any color. So I bought these at an art store. This is artist tape. So masking tape we found didn't stick very well. Duct tape also works. It works fine. It's very sticky. And then this is kind of in between. So I would suggest you either use duct tape or that you use the artist tape. And it comes in other colors too. Some places use purple to indicate that they are also a psych case, which can mean whatever you want. A mental behavioral.
Psych.
Yeah. That.
Purple for psych, my favorite color.
Oh yeah. It can be your favorite color without it implying a whole lot of other things. Because I just noticed a whole lot of people in this group are wearing color. Very popular color. I love it too. So you can also come up with your own version of how this would be. So I'm going to tag Diane yellow because she has a broken arm. So I'm just going to put a strip of yellow on her. And then the nice thing about tapes is that also if she later stabilizes, you can put the green next to it or under it or over it, or if she gets worse, you can change the red. On triage tags, you never change the category. Even if in your mind, you know, they change, they get worse, or you can get, if they get worse, you can tag them to a higher level of acuity, but if they get better and are walking around, you can't, that's the way that they're doing. Okay, so I could carry these around on my wrist. You can put them on a hook on your belt. And then what I like to do is to, she's already got a name tag, but if she didn't, then this would be her name tag. I've got her name. And then what I encourage our clinics to do, which you might not need to do, but let me explain it anyway, is that as people come in and they become part of your medical treatment, that you number them. So, and then I would just give her a number right here. And what that helps in our clinics is that if I got the name wrong, but I logged him in as Mr. Smith Gonzalez, and he's number one, that, you know, if later on we're looking and go, oh, Mr. Smith, no, Mr. Gonzalez, no, you're Mr. Oh, okay, but your number so-and-so, you came in early and you have a broken leg, okay, then I have a way of cross-checking that the medical record had number 1 on it, the log had number 1 on it, and that he had number 1 on him. And then we can adjust the name. It's just a way of double-checking. Then what I do with these is, for those of you who are nurses, this will look very familiar, that you put your notes there. So you put the date and the time, or at least the time, their vital signs, and your notes. So, I have notes that, these are your vital signs. It was, whatever time it is, it's 10:40 in the morning, and that you were in distress, but you were alert and talking to me, and I put that right here. And then I come back, a half an hour later, or, Alicia comes over a half an hour later and does the same thing. Then you put your note right here, right? And so in Haiti, the wonderful thing about that was then their medical record went with them. And if you want to keep a record, nowadays, before I used to try to come up with something really crazy, pull out your iPhone and take a picture, okay? And then you do that, and then you've got some, or you just have them on your log of, oh yeah, there was a patient who meets that description who came, and she told me her name was such and such. Yeah.
And you can put things like that they're diabetic or they have some other.
And then you could do your history, you could do whatever. And then this just travels with you. And the wonderful thing about the Haitians is that they were so conscientious that the kid would come back, 2 days later, and the t-shirt clearly would have been laundered in the meantime, and the tag would be in exactly the same place that I had put it. So, when people are conscientious, this actually works. So I love this system, and like I said, then the notes travel with them, and then those of you who have medical background, you know that sequencing is so important, and to include things like whether they were alert, their level of distress. And as a non-medical person, you don't have to say, this is a compound fracture of the whatever bone it is. Just say, that they're alert, in pain, oriented, severe pain in the left leg. That's all you need to know, because then we'll talk about doing a head-to-toe exam where you make sure that there's nothing else going on. And this actually ends up sometimes being just a record of whether they were alert, and talkative, because, if, 2 hours later she's unresponsive, but I know that when you came in you were responsive, that's huge. Or if it goes the other way around, when they first came in they were groggy and disoriented, and now they're talking about the presidential election. This is, this isn't
Then you need purple tape.
or some of us will need this. Yeah. Thank you very much, Diane.
You're welcome. Let me just ask, so this is the triage on the notes. Name tag, and there was a number,
Number.
and there was something
Yeah,
else.
go ahead and explain that again.
So triage and notes, and then you want a name over here and a number, and there was one more.
History, you could do a history.
And then you could also, do medical history.
Medical history or something.
Yeah.
Very good.
And then in terms of medications, you would not be prescribing, obviously, but if somebody has a medication that they brought with them or their family members brings over, you can hand it to them and assist them. This says 3 times a day. You didn't take it yet this morning. Do you want to take it? So you're not telling them to take it, but you're kind of facilitating, let me get you some water, I put it in your hand and you can take it. And if they can't take it themselves, then you probably should just leave it alone. Okay. So we already covered triage. So why is this important for neighbors? I already talked about it a little bit, which is that, when it comes to things like bleeding and treating for shock, which we're going to go into, that you're the folks that are here. The EMTs are going to be tied up who knows where, everywhere, basically. It's not that they're ignoring you on purpose. It's that, they're not going to necessarily be here. And there are many things that you can do that can make a difference. I stop at auto accidents, and all of the time. And many times, at the end, people say, oh, thank you so much. I say, well, you're very welcome, but medically speaking, I didn't really do anything. And they always say the same thing. They say, but you were there. But you were there. And one time my daughter called me from Chicago because she was taking out the trash. She cut her leg on something and she couldn't get the bleeding to stop. She called me from Chicago. And then while we were talking, you know, we talked about it, you know, well, do you really need 911? Did you try direct pressure, things like that. But eventually, a neighbor came by who was a nurse, who then was able to get the direct pressure on it better than she could because she kept wiping, you know, because it was hard for her to reach. And, you know, being there is really, really important. So to me, you being there, even if you didn't do something like dramatic medically, the fact that you were there was really important. And seeing what happened during Katrina, the worst was, you know, seeing bodies lying along the side of the freeway, you know, because the freeways were not, cars were not on the freeway. These were kind of just because they were elevated, that they were above the floodwaters. You know, people who died alone. Another story is that when we got to the New Orleans airport, there was an entire waiting room that was set aside for the expectants, the ones that we talked about being tagged gray. And when we got there, you know, the staff, the people who were looking after it said, you know, now this is going to be really shocking to you. Try not to be upset, but this is the area. And there were people who were, you know, had complex medical conditions who were unresponsive, but they were, you know, being looked after, you know, if they wet themselves, they were changed. Even before we get to the actual first aid, they're already identified these things that I think are vitally important. So now we're going to go to first aid, unless I forgot something. 85% of all rescues in earthquakes are done by non-professionals. So you guys doing, you know, rescues of each other is actually what happens. So we're going to skip this. Well, let me, since you might include this, because there are actually some other slides, I actually have some photos here that I can explain. Oh, they're in your handouts, of course. So, fever, vomiting, and diarrhea. So this is, right here, this is one of my little patients in Haiti. And he was brought in by his dad with fever, vomiting, and diarrhea. And he, so he wasn't that bad, and so we were teaching Dad how to give fluids in small amounts in little sips. The reason this slide here is here, though, is that at the moment we had the pretty pink stuff, Pedialyte, and that's the bottle that we gave him. But we knew that we were going to run out of this when we were in Haiti. So in all of our military ration things, MREs, there are salt and sugar packets. So we saved all of our salt and sugar packets so that after we ran out of the fancy stuff that came from a pharmacy, that we would be able to make oral rehydration solutions. So use the stuff in your kitchens, use the stuff that you have around. It doesn't have to, you know, come in a fancy bottle. The next slide shows some of the supplies that we use. If you have nothing else, the two things that I say we use the most were water bottles for irrigation and non-sterile gauze. So if, and the other thing that we used a lot, is that you can also just make bandages out of muslin. So I got these at Discount Fabrics, San Pablo and Ashby. You can also use the Joanne coupons. I would get the thinner type, the one that has kind of a coarse open weave if you have a choice, rather than the one with a tight weave, because they absorb anything cotton, you know, will work. So, you know, the sheets that no longer match, you know, the color of your wall and things like that. But if you do use people's sheets and or towels, wash them in hot water with bleach, because bleach will kill most of the bacteria, and then run them in the hot cycle of the dryer, which will kill anything else. So, and then to me, those are ready to use. So what we did with the water bottles is we took a needle. It could be a fat sewing needle, or it could be, you know, I mean an 18 gauge, you know, a regular hypodermic needle, and made holes in this. And we use this to irrigate wounds. And this is actually what we used all of the time in Haiti to irrigate wounds. So even in the emergency rooms, they do not use sterile water, they use tap water to irrigate wounds. And one of the ways that I was taught that helps people to remember is to actually feel. To actually feel. So if you will,
Yeah.
so if you will remember, I remember something about being wet and cold. Okay? That you can just use a regular water bottle to irrigate wounds. You can do so in this one there were 4. I actually sometimes I think that if you want more pressure, then I would just put 1 hole, make it a little bit bigger, and then you can get a little bit more focused. If you're kind of generally irrigating, then I would put several holes. And what we would do is we would set several of these up, put a little piece of tape on top. And the cool thing about using this is that if you don't use them, you can drink them. And if you run out of them, you run to your cache and get your water bottles. Another tip, though, is that the ones with the transparent tops are much easier to use.
Yes.
So the ones that have those opaque white tops, you have to drill a long time. So, and I just buy them at Costco. And then this is just an example of one of our members using this to irrigate a foot wound. And this is an example of when is a water bottle more than a water bottle. Mm-hmm. We cut the water bottles to make, how many of you know about asthma medicines? Mm-hmm. So there's this thing called an aero chamber that helps the patient to be able to inhale the medication better. We didn't have any of those, so we took a water bottle and we made a hole for the inhaler, and then we took another one of these and cut it and attached it here, and then we had different sizes so that then becomes an aero chamber. Use everything that you have. There's absolutely no reason to not do that. And our final really cute slide here, you can barely see it on here, but what's scrawled on the side of the box is baby in box, do not discard.
Oh my.
So we had delivered a baby and we had no bassinet. So we used a cardboard box and some chucks, you know, just any type of fabric. We put a survival blanket around the bottom so it would trap the baby's natural heat and a little something else on top. And the baby also has a cap that must have come in the delivery kit, because I don't know where we would have gotten a cap. All newborns get caps, right? But use whatever you've got. Again, you know, if you don't have a bassinet, find a box, you know, or wrap them up in your t-shirt and have somebody just sit there with the baby. You know, you can do anything like that. So this is the idea that you've got things here that you can use. If you know, I always figured that actually nobody in Berkeley is going to starve after the earthquake, because if you look in our pantries and our garages, there's enough food in Berkeley, you know, maybe not in the flatlands, but certainly up here, that nobody's going to starve. Remember that, start with the stuff that's in your refrigerator. You don't have to pull out your cans at the beginning. Somebody fire up the barbecue, all the neighbors bring your stuff, and you just kind of mush it all together and eat that. Then within a couple days hit your freezer, and then a couple days after that, then pull out your cans, and by then, you know, and share.
Water is more important than anything else.
Water could be a big issue, but I don't think food is going to be. Yeah. I don't know how much water is in this stream, but
Depends.
Yeah.
But if there's water in the stream, if you've got an REI camping filter, then you've got an additional source of water. And actually, you can pull the water out of your toilet. Filter it, though. If it's out in the tank, then you can actually just drink it. And I installed rain barrels at my house. but I'd actually like to filter it before I drink it. So I'm headed to REI pretty soon to buy
Can I
one of
ask a
those.
question?
Yes.
Are those filter kits better than those tablets?
Yeah, so hardly anybody uses the tablets anymore.
Okay.
The other one that's very popular is the photoelectric, so that if the water is clear, then you just put it into the cup or the quart, and it zaps it with ultraviolet light. And this is really handy for when I travel, because I might be in the restaurant and I don't really want to pull out my filter and in front of the waiters, kind of pour it and filter it, wait for it to come out. Whereas you could just kind of put the zapper into your water cup and zap it that way.
And what is it called?
Steri pen.
Scary?
Oh, Steri. It's like sterile. Yeah.
Pen.
Uh-huh. But REI has they have a little handout, or you can go online, that talks about the different methods that they use. But, so the tablets work, but they don't taste good.
I know they don't taste good.
So, if you've got the resources, then you can get one of those camping things that will filter, I forget several cups a minute, I think. So do the camping thing, and then you have more options for water. So sometimes people ask about legality. Can somebody sue me for what I do? And as volunteers, you are covered by the Good Samaritan Act. If you are a nurse or a doctor or a licensed professional and you introduce yourself as such, then maybe you're kind of straying a little bit past the Good Samaritan. So I would suggest when I stop for auto accidents, I say, "Hi, I'm Barbara, I know first aid." Because I'm not functioning as a physician assistant, I'm functioning as a first aid person. And so my advice to you also is to stick with first aid when you're doing first aid. And then if you end up as a volunteer in the hospital, then use your full licensure skills. But if you're doing things in the neighborhood, then stick with first aid. So we have a saying on my team, which is stay in your lane. So the things that you know how to do them. If you don't know how to do them, then don't do them, and you still have done good, because at the end of today, you're going to know how to stop bleeding and treat for shock, and that's big. Okay, so even if you don't do more, but if you do know how to do more, because you had kids, because you were a Boy Scout, because you took a first aid class, then do the things that you feel comfortable, that this is the way that I was trained, whatever the outcome was, this is the way that I know first aid. To me, that's staying in your lane, and that's good. Somebody else from the state, when we were talking about this, explained the legal part this way. There is nothing that can prevent somebody to exercise their God-given right to sue you. Okay? So they can still sue you. But the thing is that if you're covered by the Good Samaritan Act, then, then they won't prevail. Then that's kind of what we're looking for. So, but Barbara said they can't sue me. Well, they can still try to sue you, but you actually are covered by the Good Samaritan Act, and we would never expect that. So gross negligence or, malfeasance, doing something on purpose to hurt somebody. So don't do surgery in the parking lot, but stick to the things that you know. Okay, so I already talked about the things that I'm going to go over today are controlling bleeding, treating for shock. We're going to talk a little bit about splints, and then moving victims. So, victim. Come on up. And take off your jacket. You didn't know you had to do that, Fred. Okay, so Fred's got an injury on his arm and it's bleeding. I didn't bring my fake blood.
Good. Let's not use real.
We'll try not to use any real blood. But when you're doing it, for kids and for exercises, The fake blood is actually real easy to use, and you just kind of squirt it on. And so Fred's got an injury right here. So what you're going to do is apply direct pressure. Now, if I had something handy, I could use that. I could also use the sleeve of my hoodie. I could, I have at times asked somebody to donate their t-shirt. And so we're gonna put something. Okay, so this is a bandana that I happen to keep in my pocket. So I'm gonna apply this and apply direct pressure. So I'm gonna squeeze as hard as I can. Because what you're trying to do is that when blood is flowing, it will not clot. You have to slow down the flow of blood so that it has a chance to clot. So it's using its own clotting mechanism. And if I forget, remind me to talk about blood thinners. So I'm going to press as hard as I can. I'm going to use 2 hands. Now people talk about elevating. If you can elevate, that's fine. But to me, it's more important to get a lot of pressure on it. Okay, and I'm going to...
Gonna lie down or something?
Yeah, in a minute. So the 2 important things are direct pressure and don't peak. Okay, direct pressure as hard as you can and don't peak. So if this
Don't what?
don't peak.
Oh, okay.
So if this is bleeding through, I don't take this off because when I do, I'm going to break the clot, right? So then I'm going to put something else on top of that, and then press hard. And then this isn't working that well. And
I'm getting a red tag.
can somebody help me open this up so he doesn't bleed? Yeah, you're getting a red
As
tag.
long as I don't get the purple one.
Right. Okay, so pretty comatose. Okay, so the bleeding is slowing. So I'm going to put another layer on here, and then I'm going to wrap it. And then when you wrap it, all that you really need to do is to get, you want to kind of get even pressure on it. So there's fancy wraps. If you take a class, you can learn about fancy wraps. But to me, if just leave a tail and wrap snugly. So if the bleeding is slowing down, that's a time that you can then wrap it and tie it. And this is, and if you had trouble getting it to stop bleeding, that's a perfect patient to have somebody else stay with them. And, and tell the person, why don't you stay here with Fred and talk. And if he either stops talking to you or this starts to bleed more, to come over and tell me. Okay, so the question came up around what if you can't control the bleeding? So pressure points used to be taught, and they've found that even professionals have such a hard time finding them that unless you know what you're doing, it's probably not worth it. Or the other thing I'm thinking is that you would never want to stop direct pressure in order to look for a pressure point. But if you've got your hands here and you've got somebody else who says, I know how to find a pressure point, then go ahead and pull it out so that they can look for it, but don't interfere with the direct pressure. Don't compromise that in order to look for a pressure point. Same thing with elevation. If I've got a kid's hand and I can get both my hands around it and I can get good pressure on it, then elevating will help, but I wouldn't compromise the direct pressure like on Fred. To me, that would be hard because when I started doing this, he could feel the difference. I got a lot of pressure on him when I was doing this. 2 hands pressing down really hard. Tourniquets, so before I forget, there are also clotting agents, and I am compulsive enough to keep it in my purse, along with some gauze and Band-Aids. I use the Band-Aids more than anything else, right? But there are these things that are more and more available. I think they're going to be more and more widely used. And this one is called Quick Clot. There are a lot of different types. And they are good in addition to, so you wouldn't start with this unless you've got a wound that you think this is really crazy. So these actually though are good for gunshot because you can actually stuff it into the hole. But for a regular, somebody cut their arm or they've got a cut someplace else, I would not actually start with this. I would actually start with gauze. There's a lot of controversy about these, but there can be situations where you just can't quite get it to clot. The other thing is that for people who are on blood thinners, not so much warfarin, but there are other, anyway, if they're on blood thinners, then they have fewer clotting factors and things like that. There is one version of this which is made with chitin, C-H-I-T-T-I-N, I think. And right now I can't remember the which brand that is, but that one, it's developed from shellfish. And it has something that naturally clots. So that one, actually, you don't need your own clotting factor. So that one actually is good for, especially if you or somebody in your household is on blood thinners, that would be something that you might want to go ahead and grab and use a little bit faster because it does, on its own, help to clot into the wound. If somebody has a penetrating injury, you can't or a head injury, my God, you don't want to put excessive pressure on that, but you still can put packing in there. So if somebody has an injury here, you can still put gauze in there and put some gentle pressure. The gauze absorbing some of the blood will help to slow the blood flow, and it gives them a chance to clot. But this is the type of injury that they really need to get to a hospital. If it's a cut that's this big, then that's not such a big deal. But if it's a penetrating injury that also then went farther inside, with the head, you can kind of gently come around to the spot. If everything is, you can feel the skull all of the way around, then the skull is intact, but you've got bleeding above that. And by the way, scalps bleed like crazy. Sometimes you see somebody with blood all of the way down to their shoes, and you clean it up, and there's a cut right here. And that's all that it is. But you need to make sure that the bone is all intact. So, if you're getting closer and you're going, ooh, that doesn't quite feel right, don't keep pushing. Just back off and decide that I'm not sure if the skull is all intact, so we're going to put something on it, but we're not going to put a lot of pressure on it. But if if you feel like, no, that skull is all the way intact, then you can put the same amount of pressure. That question, Elena?
Where can we buy the clotting
So these are online.
online?
So Quick Clot is one of the brands. If you remind me, I actually did a write-up for one of the other neighborhood groups about the different types. It's also advised that if you get the newer versions of these, because sometimes online or on eBay, somebody's dumping a lot of really, really cheap. It's probably the older versions of these that don't work as well.
So we want something that is right now and more expensive.
Yeah, or that
That's okay.
Yeah, or do the research and find out what
Year.
what is the newer version. So the older ones did create too much heat and caused burns, or they tended to clot in funny ways. So the first generation of Quick Clot is no longer recommended. It's, I think, the third generation that's the best. So, but I don't remember all of the names in my head. I can send you the paper that is some research. Okay, so we covered, tourniquets.
I have
Yeah.
When do you wear gloves?
I'm sorry. You wear gloves all the time.
All the time. And when do you put your tag? I mean, what's the first important? That the tag was holding the guy?
The
or
holding.
do you hold
Or-
first and then?
Yeah, or hopefully you guys will have a team, so that you have, a team that's doing the tagging and the logging while you've got other people who are doing the intervening. But otherwise, yeah, the stopping bleeding. Now, so it depends. Stopping bleeding is something that you would do right away, right? And airway. Those are the two that you don't stop. You don't do anything else beforehand. But most all of the other things, you can log them in, and then, my butt, my arm's broken. You can still log them in. You could give them some comfort, but log them in, and then take a look at their arm. Tourniquets. So tourniquets have come back into use largely as a result of the wars. And they have saved many, many, many lives, and now many military units, some police departments, and even some firefighters have tourniquets, not firefighters, but police, have tourniquets actually sewn into their uniforms. They're one-handed, so that, you get shot in the leg, you can actually tourniquet yourself. We're not working in combat situations, so, to me, a tourniquet is not quite an extreme measure, but it's something that you would not go to unless you really, really, had no other way to do it. So, here, you can sit up, Fred. But I'm actually going to come back and do something. So you can sit in your chair, but you're going to come back with that injury. And yes, I should have been wearing gloves, purple gloves.
Okay. Well,
2x2 hands of blue. Everybody. What was the name of that movie? It was Nick. Anyway.
Is there something about them being purple?
No.
It's just that Kaiser got 3 zillion of them in that
Oh,
color.
the purple ones tend to be nitrile rather than latex.
Okay.
So actually there is something about
Okay.
the purple. The
The
latex
latex issue.
ones tend to be the same color as these gauze. And because of the rare but serious latex allergy, they're now going more with nitrile. These particular purple ones are really good because they're nice and strong. You can also use the plastic, I forget what, vinyl, that don't have latex.
What brand do you recommend of those? Is it just the?
No, I don't have a brand preference.
Just
Yeah, but the nitrile ones are a little bit stronger, so that if you're also doing like search and rescue or you're crawling around, the latex ones are a little bit easier to break. And then the nitrile ones are, yeah, they're kind of more in vogue now. So for you guys, that actually could be useful because they are a little bit stronger for doing the other things that you're also doing.
good.
Yeah. So tourniquets. The times that you might consider a tourniquet, it would be if you have blood that's spurting. Squirt, 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 because then that's arterial. And or if there's a pool of blood, lots and lots of blood, where you realize that this person is actually bleeding out. Messy wounds, something that you can't quite get, on a thigh, you can't quite get your hand around. But if you do a tourniquet, so you should always start with direct pressure, because in most cases that's what will work. And then have a second person trying to figure out about the tourniquet, so that you're getting that direct pressure on immediately, and you're not compromising the direct pressure in order to try to fiddle around with the tourniquet. You use the tourniquet to save a life, so sacrifice a limb to save a life. So you need to assume that they are going to lose that limb once you put on a tourniquet. Now that's not actually true. That from combat experience, they found that they didn't always lose limbs, even if the tourniquet had been on a long time. That's why tourniquets are becoming more and more in use, particularly in combat. I think also somewhat in police forces. But in your case, I think that it would be rare. But I can show you the basics of how you make a tourniquet. So I'm going to need another arm, and I'm going to need a pen or a pencil, something kind of strong. Alicia is lost. I'm going to use an obvious example where, you know, she's actually lost a good part of her hand. Sorry about that.
Okay, it's my left hand.
Yeah.
I'm right-handed.
And
A little bit so I can see.
yeah, and I can't control the bleeding. Because even if she's got a messy injury, if I can control the bleeding with direct pressure, which I probably could actually on the hand, but you know, if it was farther up here and okay, let's do it. It's farther up here. She's actually severed her artery up here. So what you do is you want to take something fairly wide. So I would want to create So I've now created something this wide. This is about what you want, at least the width of a belt. Okay.
Could you use a belt if that's all you have?
Yes, belts work fine. So I'm going to wrap it around, tie it, and then I'm going to tie the pen in there. And then you twist. I think it's called a windlass. And then you twist and twist and twist until the bleeding that's down here stops, or at least slows down, probably until it stops. And then I'm going to take this, and it'll hurt. It hurts like hell. Okay. Then I'm going to take this. Sorry, you can't see this. So what I've done is I've tied the pen in place. So I've twisted it until it has stopped bleeding. And then to keep it from unwinding, then I'm just tying that in place. Once you put a tourniquet on, you don't take it off. You never, ever, ever take it off in the field. And it's both because it's going to start bleeding again, but there's also a whole lot of other very complicated things that will happen because you actually are building up chemicals in this part of the arm that when you release this will flow back to her heart and kill her. So this needs to be taken off under a controlled situation in the hospital. So that's why when you put it on, so you don't put it on to slow down the bleeding and then, you know, and then take it off. You put it on when you feel like this person is going to die if I don't do that. So if you never put on a tourniquet in your life, then that's fine. If somebody bled out and you didn't put on a tourniquet, that was just kind of what happened. You don't ever have to put on a tourniquet.
What does the pen do?
So it tightens it.
It's your tightening.
Yeah, so when I'm twisting it, yeah, it's kind of like a water faucet where I'm making it tighter and tighter and tighter here, like that. And that's how you get the pressure. You can also buy them online. Combat T, anyway, there's a bunch of different brands. So I do not carry a tourniquet in my bag, but actually I do carry one of these just in case. And I think that these are, I mean, the most obvious use to me is penetrating wound or bullet wound, where you can get this down into where it's bleeding a little bit better than, and the full way that you do it is you put on a glove, you probe all of the way down into the wound with your finger until you find the bleeder and press on it, and then you stuff gauze then around your finger. I've never done it. I haven't had to do it. But that's how it works. Pen. Okay, sorry. Oh, I know. So what I want you to do, again in the interest of everybody remembering what they learned, okay, grab a partner and do direct pressure. And do tell your partner if you feel like, you know, oh, I not really, that doesn't feel very tight, or you could squeeze harder, it's okay.
Okay. So I guess then use your left arm, Dave.
Morty said.
Yeah.
Oh.
Oh, you know what, Tom's? I'll bow out.
Is that the bigger muscles of your hand are stronger than your fingertips. So it's good to get, that's where it's good to get your whole hand onto it, and then getting your weight onto it did make a difference for a lot of people. So using this part of your hand is actually stronger than trying to do it with your fingertips, because it's the same thing with lifting. One of the things that we'll find when we practice something like okay, so let me go back. Blanket carries are handy, but when you roll up the blanket and you're carrying somebody, you're actually using your fingers because you're having to grip the edge of the blanket. Whereas if you have something like this, you've got your whole hand, so you're using larger muscles. When I've done this training before, people said, oh wow, I can lift a lot more when it's got handles. So to me, blanket carry, when that's what you've got available, but these are worth getting.
And they're called what?
Well, there's a lot of different, they're canvas carriers with handles. So we're not going to do this right now, we're going to do this later, but there's a lot of different types that,
Are you making a list, Trish?
okay. All right, where are my notes so I can remember what I was talking about?
Can I ask you something?
Yes.
Does it make a difference to put one hand underneath and one hand on top?
We felt more pressure that way.
Yeah, if you can get your hand around and you've got strong hands, yeah, that would work well. I find that for a lot of people, though, that getting it down onto the ground, and then you guys put it on your knee, on your leg. So that's another option, where if I've got an arm and I put it on my leg, then I could put more pressure. But in general, I found putting it on the ground, and where did I put my pictures? Hold on. Here they are. So I'm going to pass this around. This is a real photo from the Boston Marathon.
Were you at that?
No, this was off the internet, but this is an excellent example of direct pressure, and this is real blood. So you can kind of see how he's got something underneath his hand, and he's got both hands on the thigh, and he's got the weight of his body that he's straddling to get that pressure on. And so this is like real life example, excellent example of direct pressure. So stare at this for a minute so that it embeds in your brain, so the next time you're doing something, a big injury, that you remember, oh yeah, it was all of the way on. You can tell he's got all of his pressure on. And by the way, the only people who died were people who died immediately. They're obviously dead at the scene. Everybody else, including the guy who had his 2 legs blown off, survived because people did direct pressure and tourniquets. And also because it was at the finish line and that's where the ambulances were, and also because Boston has tremendous medical resources. But it truly was because people moved quickly, did direct pressure, tourniquets, and transported right away that everybody died. Because if you look at some of the injuries, you're wondering, wow, he actually had lost both of his lower legs, and they made it. Yeah. So emergency responders, but yeah, remember that. So before we move on to splints, I'm going to, oh Fred, we took your thing off.
Oh, we can put one back on.
Okay. So I'm going to very quickly explain to you how to, how to take a bandage off. Okay, so why don't you come, Fred, and I'm going to rebandage you. So I did 1 layer, I did 2 layers. I even did a dish towel, and then I wrapped that up. So you want to take care of all of your bleeders first. You know, that's one of the things you're looking for. And
Barbara, honestly, you're just grabbing whatever you can.
yeah,
Yeah.
yeah. It doesn't have to be gauze on the bottom or anything like that. And then while I've got you here, Fred, I'm going to put you in shock position, which is basically the position you were last time. So, which is horizontal. So what happens in shock is that one of the things that happens is that you lose the tone in your vessels so that the blood is not getting to your brain. Also, Fred was bleeding, so he lost a lot of volume. So what you want to do is you want to get the blood to the brain and the heart, because that's what's keeping everything going, and the lungs. So being horizontal then makes that more possible, because if I'm standing up, then blood can be pooling down in my legs, and my body's trying to push the blood from my legs all the way up to my abdomen, in order to get to my brain. So when Fred is lying horizontal, then it's just a whole lot easier for the heart to get the blood to the major vessels. So any position that's comfortable, but as horizontal as possible. So I've been at some auto accidents where the victim does not want to lie down. They feel vulnerable, they're scared, or whatever. There are some people who, because of other medical conditions, don't want to be lying down. So I just get them as horizontal as they can. I always try to get them at least sitting down, and then I'll have somebody stay with them, if always. And the thing is, I've had people kind of fight me because they don't want to lie down. And what happens is that as they go into shock, they become horizontal. So, and you just don't want them to fall when that happens. So if they're already sitting down, and especially if somebody's sitting next to them, they'll kind of slump, and then you just kind of ease them onto the ground. In most of the cases, their airway will be okay. But if they are truly in shock and they go completely unconscious, then it's better to roll them onto their side. But if they're kind of conscious and they don't want to be on their side, that's okay. But if somebody's watching them so that, he's not responding anymore and he's making funny noises when he breathes, that's the time that you need to roll them onto their side to protect their airway. Okay, so we've got, actually you can sit up now, Fred. So I've taken care of all of my bleeders, treated him for shock, kept him warm, and I've splinted all my injuries and things like that. And now he wants to go home, and I've got this giant bandage on his hand, and he doesn't quite want to freak out his cat when he gets home. So the way that I do this is that I wet it, which softens the blood, and then you peel it like an onion, okay? And so I'm going to wet it, and I'm going to go off and do something else. And then I just take it off layer at a time. So I got this one off, and then I might have to wet it again, and I take it off like this, and I take it off like this. And if I get down to here and it starts bleeding again, so I've taken off kind of 2 layers, and if it starts bleeding again, I can stop and put pressure on it again, or I can just wrap it up and say, is this good enough? You ready to go home? But if I'm doing well, or I want to get all the way down, because I remember this was a dirty wound, I want to clean it before I send you home, then I would wet it, and then just very, very gently take off a few layers, and it's just a layer at a time, a layer at a time. Now it could be that I can't get all of the way down, that it's just bleeding too much, and then I'll just leave this on and wrap it up. But what you would like to be able to do is to wet it and then just pull it off a little bit at a time. And then when you get down to the bottom, it will bleed again. What we're hoping is that it'll bleed, but it won't bleed that crazy bleeding that we were really scared of. So, I expect it to bleed when I take this off, and then I'm going to clean it. Another thing that helps is, he fell down into the creek when all of this happened, and he's dirty from head to toe. I would leave this on, and I would scrub off all of this, use a hose and get all of the way around, get all that mud off. And then I would start to peel down to the wound. Because if I get the wound open and then I get all the mud into it, that's not really very helpful. So keep it covered, get all the mud off, scrub all of this off, and also it doesn't hurt him as much. And then I'm going to get down to here, and then I have this much that I need to very carefully clean. And just water. No soap, no hydrogen peroxide, just water. And then as long as it's not crazy bleeding, it's actually good to open up the wound and irrigate it with, the water bottle so that you can get as much debris out of there as you can. Because the more debris you can get out, the less infection you're going to have. Now, it could be that it's just, like too deep and it hurts too much, that you can only get some of the debris out. Then at a later date, maybe when the hospital is available or a clinic is available, then we can give a little bit of, we can give an anesthetic block or give you something really fun, so that you don't remember. Fentanyl's supposed to be very good for that, and then scrub it out. But that's the way that you would do it. And then you would get some gauze, and then when you're doing a final wrap, I would use gauze if you've got it, but use something clean, not the one that we've. I would probably not send him home with a dish towel. And then you want to get you want the pressure to be as even as you can. So I would start here and just kind of try to get smooth, even pressure on that, using it a little bit wide. And then knot it. And then in your cache, you might have some stuff that's actually designed for doing that. I noticed that in my bag, I had a little bit of something. So this is Curlex. There's, so there's different types of things, so you could save that. But on a wound that was not dirty, that was not clean to begin with, something, fell and just cut. You don't need to have anything sterile. You just want to use something that's clean. If you do have sterile things, I would save that for burns and like maybe for things around the eye or something like that. But here, you just need clean stuff. You're good to go.
My green tag?
Yeah, you're green now. And this time you can take it off and leave it off. Yay, Fred.
I got a new career.
You got a new career as a victim. By the way, being victims, they're always looking for victims. Alta Bates runs exercises regularly. The Berkeley Medical Reserve Corps just ran a really fun exercise. It was an active shooter. So we had people with, gunshot wounds and stuff. Because you get to see the other side of it, and you get to be around a little bit of that adrenaline. It's not crazy adrenaline. Urban Shield is a very controversial event, but that's coming up, and they're always looking for victims. It's kind of the SWAT of, it's the SWAT, we sometimes call it the SWAT Olympics, because they have SWAT teams that come from actually all around the world. But one of the really cool things that they're doing is they're starting to integrate that with ambulance strike teams, EMS teams, so that it's not just, the guys with the guns and killing the hostages, not trying to not kill the hostages, but it's also then now trying to get medical care safely closer to, at the Aurora, theater shooting, they set up a perimeter so the ambulances were lined up, but they were not allowed in because they thought there might have been a second shooter, and the people were bleeding to death, literally, on the sidewalk. And so they never did allow the ambulances in. At one point, one of the police officers said something like, "This is crazy." He called into the hospital and said, "So wait, we can't get the ambulances. Yeah, they're bleeding really a lot. What if I just throw them in the squad car and drive them over to you?" "Yeah, that's good. Okay, we're going to do that." and that's what they did. So I might not have all of that wording right, but it ended up that they piled the victims into the squad cars so they could get out of the perimeter and then to the hospital. So the issue of perimeters and securing areas so that medical people can come in, to me, is actually an exciting part of the urban shield, even though the gun part of it is like really over the top. But anyway, lots of opportunities to be victims. So
Where does that take place?
it's all over the Bay Area. So the two that I've done, one was a ferry with hostages on it, and it was actually a ferry at the pier on the bay. And they've also done, the other was a school where gunmen had taken over the school. So it was actually a school in Oakland, and we were part of the medical team that, we were then also learning to take orders and wait and interface correctly with the SWAT team that was going in to secure the area. And then we triaged the victims, stabilized them, and pulled them out. Yeah. So it's actually all over the Bay Area. But the Medical Reserve Corps, I don't know, I don't know exactly how you get on the list. Chin? Well, if you tell him that you're interested in being a volunteer, he will send you out the notices. Yeah. So yeah, Kin is the contact.
Can I clarify on the shock thing? You talked about putting them as horizontal as you can,
Yeah.
and somebody with them, turning them over
For the airway if they need it.
But and then also warmth is
Yeah, okay, that's a really important point that I kind of glossed over. Keeping them warm is really, really important. Anything that you can get under them, between them and the ground, is really, really helpful. Because in the Bay Area, the ground seldom actually gets warm. And sucking the body warmth actually increases their shock. So you're absolutely right. So getting something underneath them. At a recent event, they used kind of like the exercise mats. Those are relatively inexpensive, and they provide both a little bit of cushion and that warmth issue. The survival blankets, those are good. And even something like this, although this doesn't actually provide very much protection at all. But if you're going to go out and get something, probably something like the really thin exercise mats, the really skinny one. Yeah, I guess that's what they're like.
They're closed cell, so
Yeah.
that means that things don't. Yeah, they're closed cell.
Yeah, so inexpensive, something like that would be good to, and then you could also get red, yellow, and green if you want to kind of have that help to define your treatment areas and things like that. But that's a very, very important point. Put something under them, put something over them, and is really important. And the best position is actually on their side. So I had Fred kind of on his back, but somebody kind of the way that people sleep, so that I don't want to lay on the voice thing. But if you put their arm under their head and then just kind of in the sleep position is a good position.
So years ago when I first aid thing I ever did, I thought I remembered they told people to elevate people's feet.
Yeah, it's the amount of help that it gives compared to making it complicated to lay them down didn't seem to be worth it. If there is a way to do that, because to elevate their feet, they would need to be on their back, and then we worry about their airway. But if you can, it's not a bad thing to do, but if it interferes with them being in a comfortable position, because on your side you can't quite do that. But the universal position is kind of the sleeping position with an arm under here. And if you roll the upper leg over, then that also kind of helps stabilize them. You could put something behind their back so that they don't kind of roll back. But having one of your greens stay with somebody who is a good idea. But pull out, get your neighbors to bring out the coats and the blankets and things like that. That's a really important thing about treating shock. I'm glad you brought it up. Yeah. Yep. Okay, so splints and immobilization. The important thing about splinting is that you should splint it in the position that it is, and that you can use special things or simple things. So these are rather expensive. These are ridiculously expensive. I think these were $9 or $12 each, but they're kind of handy dandy because they're already padded.
That's not that expensive.
Well, if you're going to buy a lot, to me it is, considering what it is. Yeah, it's cardboard with some foam on it.
You could just make it out of
Yeah, here's another one that's also already folded. They come in different lengths. You can also just use regular cardboard. The tricky thing about splinting, though, is that all of the splints are completely flat. There's no part of the human body that I know of that's completely flat. So if you're splinting like a wrist, you can see that there's gaps in there. You have to pad those gaps so that if I was splinting my hand, I would put a pad there, and I'd probably, you know, unless the fingers were involved, have the fingers go over. And then you're also going to want to then pad, whoops, along the sides. So let me actually borrow somebody's arm, and we'll do a real quick demo here. Okay, so I'm doing her hand. Hands are really handy dandy. And I can see a gap under here. So I'm going to put some gauze. Under there. By the way, you can't be quite this cavalier about this. They'll be screaming. You could also, and then I'm also going to put some gauze,
Get them to talk to somebody else.
yeah, on the side. And then when I wrap it, I'm going to pull the edges up. So then I've got some stabilization here. I've got a little something underneath there. She can wiggle her fingers, and then I can also check her fingers to see, you know, can you feel this? And then I could see if they're purple or they're pink. And then, so actually, this is a really cooperative patient. Can you hold this?
So are you saying all these little gaps?
You want
on
to
the side?
You want to, yeah,
Step in.
fill the gaps. So this is actually okay because I filled the gaps on the side and under the wrist. I could also put a little something under here. That's probably, how does that feel? Blood.
You just don't want any movement.
Right. Yeah, you don't want, the thing is,
Shift around.
you don't want it to move. And like I said earlier, if you're not sure if it's broken or not, then splint it anyway, because it provides actually a great deal of comfort to be, even if it's not broken, it provides a great deal of comfort. And so,
How tight do you tie it, Barbara?
just so that the bone ends are not moving. You don't want it too tight because I don't want to compromise. Does that feel too tight right there?
It's not too bad.
Yeah. So I want to go back and be checking and make sure that she still has sensation and movement in her fingers. Now, this could work for an injury right here. But you want to splint, so wherever the break is, you want to splint below and above. So I've now immobilized her wrist, but I have not immobilized her elbow. So there's a couple of ways that we can do that. One is many uses of a hoodie. So one thing that you can do There you go. And I could tie this off, and then this then becomes her sling. Another way to do this, although realize this actually gets a little bit tricky, is to put your arm in here. The last time I did this, I actually had a little difficulty figuring out how to zip it.
Oh, because you zipped it? Oh.
Yeah. But if you've got, yeah, actually, that's what I did. I think. Let me see if I can figure out what I did. And that you could put it in there, and then you could figure out what you know, with the rest of this. But what I found is that there's a way that you usually do it where you put the sling over the back of the neck. It hurts like crazy after a while because it's a narrow piece. Whereas if you use your clothes, there is another way though. I'm trying to remember what it is. That elbow in and hand out. There you go. That's another way to do it. So, but I think the one that works the best though is probably.
Did you zip it first?
Is the one where you wrap it around the back of the neck. And you also can do this, but like I said, after a while it hurts at the back of the neck, but that's kind of the most fundamental thing. And the other thing that, yeah, you actually could do is if I had cut off the sleeve, you know, if I'd cut off the sleeve on the hoodie before I did the splinting, then it does just kind of go like this.
So the point is to get the elbow stabilized this,
Right.
so it's not just doing this kind of thing.
Exactly. So the not accounting, you know, figuring out a way. So if I had something that was wider, like a scarf that didn't hurt so much, it would be more comfortable. But if I can get this elevated to stabilize the elbow, then I would take something big. Oh, that's way too high, huh? That didn't work. Okay. Okay, drop it down a little bit more. Okay, if I had a longer piece, then I would also wrap something around here, and that would keep her elbow in close. Or I would just simply stick her inside of her coat and zip the whole thing up. And then that keeps it inside. But another lesson is that you don't have to put it into a splint. So I've had mostly Berkeley High students come in and say, I think it's broken, I think it's broken. They are splinting it. This is fine. You don't have to do anything to this. I don't need to rip it off and, you know, no, I got to put that into a splint because they're going to be screaming at you. Fractures hurt incredibly. And once you get the splint on it, it's amazing. I had a girl, she fell on the basketball court and she was writhing on the floor, wouldn't even let me get near her. But once I got this, you know, and they had to stop the game, once I got the splint onto her arm, she was able to get up and walk off the court. So the splint is huge. You know, people talk about, you know, what about, you know, what kind of medicine should we give? You know, should we give codeine? To me, a well done splint is better than codeine because then the bone ends are no longer moving.
Did you say you do it in whatever position the bones are in?
Yeah, so if they're crooked, then you would. So that's the other. Then you would splint it that way, which would mean you'd probably have something stiff and then a whole lot of padding under here, or maybe you would pad it this way, or, you know, if it was that crazy, I would just do this and wrap it against the body. So if somebody's got a lot of injuries and they're on the ground is a splint. you actually don't want to move them unless they're in danger. You don't need to, I have to put you onto this thing and carry you over there. If, think, wow, they kind of hurt all in here and they might have hurt their pelvis and their leg and stuff like that, I would leave them on the ground. We're going to do a head to toe. I would do the head to toe exam to figure out where they hurt, but I don't need to actually move them unless you have a very specific reason, and we'll run into a few of those.
But you're saying that even if someone is just holding their arm,
but that works.
Just keep doing that.
Yeah.
Just stay in that.
And then at some point, if it's feeling a little better, I kind of want to go, can you do something? Then at that point, you would figure out a way. I would get an assistant to help hold everything in place. So it's really actually hard to splint all by yourself, unless you're a super experienced, super duper ER doc or something like that. So you have one person just kind of holding it in place, an assistant, and then another one will slide the splint underneath, and another one is adding the padding and wrapping it. You want to move it the least that you can, because once you screw up and and it moves a lot, they may not let you near within 10 feet of them again for a good period of time. Yeah. Okay. And there is a special type of splint material that I like, but it's a whole different training that they use in the emergency rooms. And maybe at some point I'll do something for the whole, all of the neighborhood teams or something like that for people who actually want to learn this advanced splinting technique. But it's really nice because you can get it, you can mold, if the bone is like this, you can actually make the splint go like that.
We do have the round roll.
You have the SAM splits? Yeah, so SAM splints are good for some things, but it doesn't have the flexibility that the 3M, they're called orthocast splints do. But yeah, it's good that you have the SAM splints. So so those are orange on one side, blue on the other? So that the way that those work is that you can bend them different ways until you turn up the sides. Oh, and so this is what they look like. Okay. So these are called SAM splints. The EMTs use these a lot, because you can get blood on them and stuff like that. I find that when I try to actually use them, though, that I can't get them to mold in the ways that I would like. So, but the way that these work is that you can move these into different positions, but as soon as you turn up the sides, they become stiff. So this part is stiff, but I still can't quite get, so it's a little bit tricky to get this part up, but that's what you would do for something like this. You could actually.
Theoretically, you shouldn't have to pad that one, or you still.
Well, you still have to pad it, but you can get a lot. You can get a little bit more shape. So I've been able to get some shape here. Then you can actually run it up the back of my arm and get some.
So if you take the sides down, is it flexible again?
Yeah. But I still don't, so I can get this to where it's stiff here, but I still need padding under here. And I can get some stiffness back here, but I can't get the stiffness at the elbow. So that you would need to ad-lib something there. And then, yeah, as soon as I straighten out the edges, then it's flexible again. And these are good for ankles. And then you can stiffen it up here for ankles and feet. You also could use it this way on an arm or up. There's actually diagrams on these, on a lot of the different ways that you could use these. So these are handy, and you activate them you make them stiff by rolling them, but you still have to be it still needs padding in order to get it close enough to what you want. And it's quite stiff. Oh, now I got it dirty. It's quite stiff once it's you push up the sides.
And these are available online too.
Yep, they are, and they also were in your. This was a separate cache, right? Or is this the main cache?
It's in the main.
It's in the main. I think maybe they are, and they come in different sizes. So that's the SAM splint. Okay, splinting. Burns. There's a whole algorithm for figuring out what % of the body is burned, but anything that's bigger than that eventually needs to go to the hospital. It doesn't have to go to the hospital immediately, but it does. So first degree are like a sunburn, it's red but not blistered. Second degree are blistered. And third degree actually penetrates down into the flesh and usually tends to look charcoal-y. I haven't actually had to see any of those. But any burn that's more than, so first degree burns where the skin is intact, they don't have to go in for medical care unless it's really extensive and they need then the care for pain mostly. But if it's second degree with blisters or worse, then you do want them to eventually get into care. It doesn't have to be in the first few hours when they're taking care of bleeding and things like that, but infection is very, very high with burns and an extensive burn over a lot of the body. So if it's extensive burns, then you do want to get them to the emergency room as soon as you can. You know, if it's a burn that's this big that needs to eventually get seen by a clinician, but you don't have to like batter down the door at the emergency room. But an extensive burn, you do want to get them in, and you just want to keep it as clean as you can. Burn gel does help. So that's one of the things that you might consider putting into your cache, so that if you have somebody with a burn that's that big, you can put some burn gel, which will ease the pain. That can wait until tomorrow. Any burns that involve the face, they may have also then inhaled the heat, the smoke, and that is a medical emergency. And then also hands and genitalia are also high risk for a number of complications. But the one that's a huge emergency is if they have burns on the face, and especially if there's like soot or singed hairs and things like that, then you're worried about damage to the lungs, and that needs to go to the emergency room. If it's kind of burns, you know, on the extremities, then it's more keeping it clean, pain control, and kind of gauging the situation as to how soon you can reasonably get them into the hospital. Burns, hygiene, protect yourself from body fluids. Yes, wear your gloves. The other reason, so I actually love hoodies because it keeps me warm. It also can be smoke, you know, in the BART trains. You know, I can use it as kind of a smoke shield. And I can also use this to put between me and somebody else that's bleeding. Or I could take it off and put that between me and somebody who's bleeding. So use your clothing or anything else that you have to keep you some distance from blood. I think that now that the HIV epidemic has kind of switched gears, people are a little bit less freaked out about having contact with blood. Actually, unless you have big cuts on your hands, the likelihood of you getting HIV from handling somebody else's blood is really, really, really small, unless you get also cut. But hepatitis B, you can actually get through intact skin or getting other. So I think you can actually get a vaccine for hepatitis B, you know, if you're thinking that you'd like that additional peace of mind. But you want to just keep, you know, it's their blood, not your blood, so you do want to wear gloves or whatever you can get between you and them. And then, you know, you just use your judgment. You know, some people say, I'm not touching that. That's fine, you can do that. Or you can say, I don't care, he's bleeding, I'm going to help him. You know, that's your personal choice. But I used to carry gloves in my purse along with the quick clot. And I use them once. Hygiene, head to toe exam. So this is the last thing other than, so we're going to do head to toe exam, and then we're going to do moving patients and doing the log rolling. So head to toe exam is exactly as it's called. It's from the top to the bottom. So I need another victim. We'll grab another, you're Tom. Okay, so you can lie down here, Tom. So what injury would you like to, or why don't tell me your injuries, but do them as I get to them.
I should make one up.
Yeah, figure out what parts of your body is injured. So head to toe exam, I start, so I've already looked to make sure that he's breathing and then there's no obvious bleeding, okay? Because I would take care of those two things right away. Difficulty breathing or not breathing, I would reposition the airway. And if he's still not breathing, then I would, officially you don't need to do anything beyond that on an adult. You could give a couple of rescue breaths. If they still don't respond, then in a disaster, then they're considered to be dead, even if their heart is still going. If he's your only victim, then go ahead and do, all of the things to try to get him going again. But if there's a lot of victims and he's not breathing and he doesn't breathe when you reposition the airway, you probably would go on to the other victims, probably. Question?
This is embarrassing from CPR, but I never use it, so I don't remember. So how do you assess that someone's breathing? What's the first way?
Just look, listen, feel. So you could put my hand on his chest, or I could look at his chest. In adults, actually, it's their belly that you see moving more than their chest, but you also can do that. And then listen would be to hear the breathing. Normal breathing you actually don't particularly hear, but if they're having trouble breathing, actually when people die, oftentimes their breathing is and then you can also feel to see if there's anything. But I mostly look for chest movement. And then to reposition the head, you can just push the jaw forward, or you can just kind of tilt the head back. Okay, so, but Tom here is actually alert, and but he's on the ground. And so Tom, how you doing?
Oh, I hurt.
You hurt?
Oh,
Where do you hurt?
Oh, down there.
Down there. So it helps to find out ahead of time so that I know that when I get to that part of his body that I'm going to be careful rather than smashing on everything. So Tom, I want to check you from top to bottom just to make sure, and I'm going to be kind of feeling you to see if there's any other places that you might be injured. Is that okay with you?
Okay.
My name's Barbara. I do first aid.
Okay.
Okay, I'm going to kind of slide your hat off here. Okay, so I'm going to start here. Actually, you're going to be more comfortable with your hat under your head. It's lumpy here. Okay, so I'm just going to start here. Does any of this hurt?
No.
So I'm feeling all of his head.
Okay.
Any of this hurt here?
No.
I'm going to feel behind your neck. This is an important place. Does any of that hurt?
No, it's okay.
Do you think you hurt your neck?
No, I think I hurt my ankle.
Okay, can you turn your head side to side? Okay, good. Okay, and I'm going to check your shoulders. Does any of that hurt?
No, that's pretty good.
Okay. Does this hurt? Okay, now I'm going to come around and do his back in a little while. And how about your belly?
No, it's fine.
Okay, great. I'm going to feel around the side. Does that hurt? Okay. I'm going to check this arm. Does that hurt?
No.
How about here?
It's okay.
Can you squeeze my fingers? Great. And you can feel my hand?
I can.
Excellent. Okay, and I'm going to do the other side here. Can you squeeze my fingers? You can feel my hand and all of this. Does any of that hurt?
No.
I actually could have started with having him squeeze my fingers, because then if he's got an injury farther up his arm, it might register. They say, oh, wait, it actually hurts on my elbow, or, that hurt. So all of the way up.